Hello friends, in today's video we are going to learn about how to manage a case of rheumatoid arthritis. Myself Doctor ATP. First of all, how to diagnose a case of rheumatoid arthritis. A patient present with multiple joint pain with specifically morning stiffness. The stiffness goes on as patient doing some work. With history of more than 6 weeks, with investigation suggestive of RA factor and the anti-CCP positive with the high CRP and ESR. These are the criteria for the diagnosis of rheumatoid arthritis. One another criteria which is the ACR criteria for the diagnosis of rheumatoid arthritis. ACR means American College of Rheumatology, which gives some criteria to diagnose a case of rheumatoid arthritis, which include joint involvement, serology, acute phase reactant and the duration of the symptom. If a score is more than 6, that means a patient is having a definitive rheumatoid arthritis. A score more than 6 suggestive of definitive rheumatoid arthritis. The first one is the joint involvement. The joint involvement, if one large joint involved, then the score is 0. The large joint means a shoulder, elbow, hip, knee and the ankle. These 5 joints are known as a large joint. If patient is having a pain in the 2 to 10 large joint like this above 5, shoulder, elbow, hip, knee and ankle, then the score is 1. If patient is having a pain or the 1 to 3 small joint involved, then the score is 2. The small joints are MCP, metacarpophalangeal joint, proximal interphalangeal joint, thumb interphalangeal joint, metatarsophalangeal joint and the wrist joint are known as a small joint. If 4 to 10 small joint are involved, then the score is 3. If more than 10 joint involved with this one, at least one is the small joint, then the score is 5. The second point is the serology, means the investigation like rheumatoid factor and the anti-CCP. If both are negative, then the score is 0. If both are low positive, then the score is 2. And if both are high positive, then the score is 3. Low positive means less than 3 times of upper limit of normal and the high positive means 3 times of upper limit of normal. Acute phase reactant like the CRP and the ESR. If both are normal, then the score is 0. And if both are abnormal or high, then the score is 1. If duration of symptom is less than 6 weeks, then the score is 0. And if duration of symptom is more than 6 weeks, then the score is 1. If total of the score is more than 6, that's suggestive of rheumatoid arthritis. Now, how to treat a case of rheumatoid arthritis? The treatment of rheumatoid arthritis is divided into the 5 large subgroup. The first one is the NSAID, non-steroidal anti-inflammatory drug. The second one is the glucocorticoids. Third one is the DMARD, disease modified anti-rheumatoid drug. This is the specific drugs used to prevent the progression of the disease. DMARD, disease modifying anti-rheumatoid drugs. As the name suggests, these drugs are used to prevent the progression of the disease. The fourth one is the biological DMARD, biological drugs. And the fifth one is the small molecule inhibitor. This is the 5 group which are used to treat a case of rheumatoid arthritis. We will discuss about all 5 groups in detail in the subsequent slide. The first one is the NSAID, non-steroidal anti-inflammatory drugs. NSAID is the adjunctive agent for the management of rheumatoid symptoms. This is not disease modifying drugs, but this only manage the symptom of the rheumatoid arthritis. It has both analgesic and the anti-inflammatory properties. The drug which is most commonly used is the naproxen. The dose is 250 to 500 mg once or twice in a day. This is the first group and this is most widely used, but it used to treat only symptoms, not to treat the disease or the progression of the disease. The second group is the glucocorticoids. The glucocorticoids are used at the 3 level. The first level is to achieve the rapid disease control before the onset of fully effective DMARD therapy. Disease modifying anti-rheumatoid drug, it takes few weeks to month to 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 start its action. So during this initial period of few weeks to few months, we require the disease control by the glucocorticoid therapy. This is the first use. The second use of glucocorticoids is to manage a acute exacerbation or the flares. Sometime what happen, a known case of rheumatoid arthritis patient presented with the severe joint pain. Then this is known as exacerbation or flare. In this case, we can also use the glucocorticosteroid. The dose is depends on the exacerbation and it should be given for small period of time like 1 to 2 weeks. A third condition when the glucocorticoid are used in the rheumatoid arthritis is the chronic low dose administration for the patient with inadequate response to DMARD therapy. Sometime what happen, patient is already on the 1, 2 or 3 DMARD therapy, disease modifying anti-rheumatoid drug, but patient is having a continuous pain. Then in this condition we have to give continuous low dose of prednisolone. The dose is 5 to 10 mg per day. This is the three condition when we have to use glucocorticoids in a case of rheumatoid arthritis. Now the third most important group of for the treatment of RA is the DMARD, disease modifying anti-rheumatoid drugs. These drugs having a ability to slow or prevent a structural progression of the disease. But the thing is, it requires the 6 to 12 weeks for the onset of action. Conventional DMARD includes methotrexate, HCQS, hydroxychloroquine, sulfasalazine, and the leflunomide. Methotrexate is the choice of treatment for the rheumatoid arthritis. A dose is to start with the 10 mg. We can increase up to 25 mg once in a week. We can give it orally or subcutaneously. The second drug of DMARD is HCQS, hydroxychloroquine. The dose is 200 to 400 mg OD or BD as per the requirement. But HCQS is used as a add-on therapy. We cannot use HCQS as a individual drug. We have to add on the methotrexate when a patient is having a continuous complaint despite of patient is on taking methotrexate. Then we have to add the HCQS along with the methotrexate. The third one is the sulfasalazine. The initial dose of sulfasalazine is the 500 mg BD and the maintenance dose is 1000 to 1500 mg BD. The fourth one is the leflunomide. The dose is 10 to 20 mg per day. These are the four conventional DMARD which are most commonly used to treat or prevent the progression of the disease: methotrexate, HCQS, sulfasalazine, and the leflunomide. A fourth group is known as biologicals or biological DMARD. These are the first one is the anti-TNF agent, which include infliximab, adalimumab, golimumab, certolizumab, and the etanercept. The second one is interleukin-1 antagonist, which is anakinra. The third one is abatacept. Fourth one is the rituximab, and fourth one is the tocilizumab. These are the biological drugs which are used when a conventional DMARD are not useful, or we can give this biological DMARD along with the methotrexate. A fifth group of drug which are using for the treatment of rheumatoid arthritis is small molecule inhibitor. Some patients do not respond to the conventional DMARD or the biological DMARD. In this case, we have to add the small molecule inhibitor, which is the tofacitinib. The dose of tofacitinib is 5 mg BD or 11 mg OD. The mechanism of action of the tofacitinib is it inhibits the JAK1 and JAK3 receptor. These are the all five groups. The first one is the NSAID, the second one is the glucocorticosteroid, third one is the conventional DMARDs, fourth one is the biological DMARD, and the fifth one is the small molecule inhibitor. Now, how to approach a patient of rheumatoid arthritis? First of all, we have to start with the methotrexate. Methotrexate is the first choice of treatment in the DMARD group. If a patient is not responding to the methotrexate, then we can give oral triple therapy like methotrexate plus sulfasalazine plus HCQS. All three are the DMARD. Or we can give other group like methotrexate plus leflunomide, or we can give methotrexate plus biological DMARD. This is the choice of treatment according to the patient and according to the condition of the patient. Now this is the treatment sheet of one patient which I describe for the explanation. We can, if patient present initially, we can give the methotrexate 10 mg once a week like every Monday. We have to give folic acid along with methotrexate to prevent its side effect, but we don't have to give the folic acid on the day of methotrexate. So we don't have to give folic acid on the Monday if we are giving the methotrexate on Monday. HCQS is 200 mg BD. Naproxen and prednisolone we have to give for 4 to 6 weeks because methotrexate requires a 4 to 6 week for its action. So during this time we have to give the naproxen and the prednisolone. As the patient become asymptomatic, then we can stop the naproxen or we can give in SOS and we can stop prednisolone. We have to continue the methotrexate, folic acid and HCQS lifelong for the treatment of rheumatoid arthritis. Thank you so much.